Okay, we can see your slide. Yeah, there. It's in presentation mode.
So I still see people joining, so we wait 2 minutes more maybe.
Yeah. So, Beate, how long will be the presentation? Do you think we'll be able to take questions or queries at the end?
Sorry, I currently don't see anymore my presentation. Do you see my presentation?
Yes, I can see your slide. It's in presentation mode.
So let me check why. No, that's strange. Because I now see all of you, but not anymore my. Do you still see my slides?
Not now. We can see you, but you may try sharing your
So
screen
maybe
again.
I do it again. Maybe that will help. Here it is.
Yes.
So I think I'm fine to be with you until 4:15 if needed. Or I have more than 1 hour. Let's put it like this.
Okay. But your slide is not in presentation mode right now. Okay, it's now in presentation mode. If you can just check, it's moving. Yeah. That's no problem. I think we are good to start. We should.
Okay. So Bilal, if you allow, I would like to welcome all of you to the first educational lecture on pediatric radiation oncology. So this is a joint initiative of my center here offering pediatric radiotherapy and the SIOP GHN PROS working group. And I think it's really, really great that we can offer something to help you managing children under radiotherapy. So this is the particular focus of a series of lectures. And we want to consider both CNS and non-CNS tumors. And it was for me particularly important to offer this to the colleagues within ELMIC, also due to the experience we were having with Adedayo Joseph from Nigeria, who was here, and I felt whatever we can offer to help you to share experiences, I think is what we want to do. So, and I'm also happy that this is not an initiative of me personally alone or so. Lots of people here from the societies are willing to contribute and to offer also lectures. So we will have every quartile a lecture on pediatric radiotherapy for different entities. And this is just the first 1.5 years, let's say. But if this is a kind of success and you feel it's helpful, we can have more lectures to come, because I know that many people will be motivated to do it. And yes, I would wish that this is the start of something which is of help for you. So I felt that we could start today with a kind of a little bit background and some general principles rather than going into an entity right now. So this will be really general principles. You may know this already, but I think still it's a good start for our lecture series. I want also to start with a disclaimer, because you may know that I'm from Europe, from Northern Europe, from Germany. And of course, I know that the situation I'm having here may be very different from the reality you are working in. So what my experiences are and what I say may not be fully transferable to your situation. So when I prepared for this today, I was wondering, should I adapt, let's say, my view in order to better meet your situation? But I felt, no, I should not, because I don't know the situation you are all in, and it may be very different from side to side. So I think at least I want you to know that I'm aware of the fact that I'm in a very privileged situation and you may not be, and that you have to decide what you can derive from it for your specific situation. So but it is impossible for me to fully adapt to your place. I hope you understand this, and I hope that you still find it interesting and maybe useful for your work life. So I felt today I could give a little bit background, talk a little bit about the challenges we are having with pediatric radiation therapy, explain a little bit the evolution of the strategies in radiotherapy of pediatric diseases, and of course also finish with some conclusion. So I think you are all aware that radiotherapy in childhood cancer is a very powerful tool which we need to achieve local control. And we use this tool particularly if tumor is unresectable or not fully resectable. Radiotherapy was undergoing and still is undergoing continuous evolution. And this is the same true, of course, for general oncology or pediatric oncology. It is also, I think, a challenge that RT is increasingly complex. It's complex because we have technical developments on one hand in radiotherapy. On the other hand, we have a high, let's say, speed of new information coming in from the general field of oncology with regard to risk factors, for example, with biological or molecular findings, which we are supposed to include in our treatment decisions. So I feel it's very difficult to always be on the top of the knowledge. And we have to admit that all of us, also me being here in my place, we feel that we are not always, it's not always possible to take all the news into account which we receive. And in a way, we have to find our best way to deal or to offer good radiotherapy within this moving target, let's say, of pediatric oncology. So what here is very important in Europe is that that there was a little bit a change of priorities in oncology care. So we had times when the survival of pediatric cancer was quite poor. And at that time, we tried to intensify therapy in order to make children survive. Nowadays, this is a little bit different. When we do administer, let's say, gold standard therapy, then we see that we have already excellent survival rates in many diseases. Maybe not in all, but in many. And so therefore, lots of the strategies have changed the aims of not anymore increasing survival rates, but rather to reduce the risk for late effects. So once we have achieved high survival, we want to reduce the burden of therapy. And this burden of therapy, I think we all understood, is particularly high in children. And that is due to the fact that the child is growing and maturing. And here this is German, but don't bother. It's not a problem. So here we have the years of age, and here is the relative growth. And then we see how different kinds of tissue are developing or are growing. So we have very steep growing curves here for lymphatics or neural growth or general growth or reproductive growth is a little bit more behind here, the growth curve. But typically, we have a lot of growth, let's say, during childhood, and our radiotherapy is interfering with the growth, not only of the cancer, of the tumor, it's also interfering with the growth of the normal tissue, which is shown here in this curve. So we have to take care that we are interfering with growth of bones, for example, or organs, and that this may also have impact on functionality of different organs or tissues. And this, of course, is a particular challenge we have in children. And it's even more difficult that lots of children are not older children. Lots of them are very young children. So when we look into several entities or diagnoses here, like ependymoma, choroid plexus tumors, ATRTs, neuroblastomas, retinoblastomas, nephroblastomas, rhabdoid tumors, or extracranial germ cells, you see all of them are at 4 years of age or below, here 1 year of age, 3 years of age. So a huge group of children who need cancer therapy who are extremely young. And this is also, if you look here, if you look at the age of 4 and below, this is already nearly 35, or is more than 35% of all diagnoses are in the age of 4 and less. So we have a tremendous issue of offering cancer therapy to very young children, where we have also negative effects to be afraid of. Still, we have understood, even if we are afraid of late effects, that children may need still radiotherapy. We did not achieve to compensate for radiotherapy by offering more chemotherapy. That's not the fact. We still have lots of diagnoses, and this will become clearer, of course, during the series of lectures, that many children deserve to get radiotherapy, even if we are afraid of adverse side effects. However, the burden is significant by late effects and also by secondary malignancies, which may be even fatal for some of malignancies. And that's a problem, but also, on the other hand, we have to also acknowledge that typically the cause for this burden of therapy is multifactorial. So it's not always all attributed to radiotherapy. We have individual effects, we have combination effects with chemotherapy, we have maybe some trauma due to the tumor compression or surgery. So that's a multifaceted thing. However, even if we know that also other disciplines will contribute, we all know that we try to find the least damaging modality. If that's true for radiotherapy or chemotherapy or whatever, we are trying to find tools which cause the least damage. So here's some list of what we know can be the price of survival: neurological deficits, growth disturbances, endocrinopathies, psychosocial issues, neurocognitive decline, infertility, secondary cancer. And this list is not complete, of course. And as I said, we have different contributing factors, and some of them we can hardly kind of impact on. So if a child comes with young age, we have to deal with it in a way. Or maybe the child comes with some predisposition syndrome, and we still have to find a way to offer a curative treatment. So we have a very complex situation. This is also reflected from the data we have from the literature when we are looking into data on late mortality in children. Of course, we still have some deaths from recurrences, but we also have deaths from second neoplasm, heart disease, and more reasons. So therefore, we know that the mortality of children after cancer therapy in the survivors is still an issue. So what do we do with regard to radiotherapy? I think what we have learned is that we need to offer risk-adapted, individualized treatment. So this means that we should never offer too much therapy. It should be adapted to the risk for treatment failure. So if we have a high risk, we may need more intense therapy as compared to a low risk situation. And I think in principle, radiotherapy is a very powerful tool to do adaptation. However, of course, to understand the individual risk, we need the partners from pathology or pediatric oncology to understand the risk situation of each patient. So what can we do? I think what is really important is that we have an optimal information on the patient and on the disease. If we don't know enough about the patient, it's very hard to understand what the optimal radiotherapy strategy for this patient would be. And this information we typically receive, at least in our case, from pediatric oncology, but also from the family. But here, pediatric oncology is kind of the manager for the family and for the patient. This may not be the case in your place, and then you may need to go to every single colleague to have information from radiology, from pathology, from surgery, and from pediatric oncology. And of course, you also need information from the family, how patient is doing and if there are any deficits, etc. So, but this optimal information is very important in order to offer best therapy. You need to know exactly what disease you have, what is the extent of the disease, and what is the situation of the patient, what burden can this patient tolerate. So, and then I think the first question is, of course, do we really need radiotherapy? We need to justify to give radiotherapy to a child, of course. It needs to be justified. And this is the first question to answer. And it may also mean that you have to look for the other modalities, like is there an alternative option causing less morbidity or promising higher survival or local control rates, or can you combine and complement radiotherapy maybe with other modalities? And in this context, it's also always the question of timing. When is the best time point of delivering radiotherapy? I cannot give an answer of this because this depends on the disease and lots of factors. But as I say, this will be maybe clearer during the series of lectures. But it may be possible to postpone radiotherapy in the case that the child is very young and that there is, for example, effective chemotherapy to delay radiotherapy. So this is also an important question. Does the child need radiotherapy? Yes, no. If the child needs radiotherapy, the question is when? Can I delay? Can I allow a longer time of normal development before I interfere with radiotherapy? And then, of course, I can kind of trim my radiotherapy in terms of selecting the appropriate dose, selecting an appropriate fractionation. So how many gray per day over how many days or weeks. This is something I can play with in order to accommodate to the risk situation of the tumor, but also maybe to the, let's say, life circumstances or social circumstances of the patient. What is the target volume of radiotherapy? Is it a small volume? Is it a large volume? Of course, it should be as small as possible to achieve cure. Should never be too large. So overtreatment is something we do not want to see in children, particularly if they're very young. What technique of radiotherapy can we offer? Of course, this depends very much on your on the resources you are having in your place. But as I'd say, in general, of course, it should be a technique which is as conformal as possible if it's available for you. And then, of course, we also need to take care that quality of radiotherapy need to be appropriate. So I can give a good radiotherapy and I can give a bad radiotherapy. And I will come back to this and give some examples. So just one example here for the decision to treat. I said, does the child need radiotherapy, yes or no? There are very important, these are very important questions, particularly in the very young age group. So the atypical tera-rhabdoid tumors, which were also on the list in one of the first slides when I was talking about young age, they are typically very young. So we were investigating a group of these tumors arising in very early childhood. The median age of this cohort was less than 1.6 years of age. And so we were looking at this cohort in terms of, do we need to give radiotherapy? We do not want to treat children at that age. And when we were looking into that cohort of nearly 200 patients, we saw that the patients not receiving radiotherapy, which is the green line, had nearly no chance to survive. So after 3 years of age, only 12% were still alive in the group of children not having received any radiotherapy. So in this case, we feel that even in young age, it is justified to offer radiotherapy. We still may accept if parents decide against it. However, I think we need at least to offer it. And this is what I mean about justification. Of course, we cannot give radiotherapy just because we want to use our LINAC, but if we have data to prove that it's an important tool to achieve tumor control, it may be something we want to offer. I said we should not be too large, and I think this is something we learn for brain tumors, for example, over a long time. We know that there is a high morbidity when treating cranial or CNS tumors. And when we look into the past, into the history, nearly all children received craniospinal radiotherapy, regardless of the diagnosis. This was done since 1930 until, I would say, 1990 or 1980. And then people understood, no, you don't need to treat the full CNS for all tumors. You have to adapt your target volume. So in some children, for example, like germ cell tumors, we may treat only the ventricular system, but avoiding whole brain and whole spinal irradiation. And the majority, fortunately, today receive even only local tumor bed RT. So the majority of CNS tumors are only treated today with local fields, like here, this image in the middle. Only a minority of patients, typically the ones being metastasized already, will receive craniospinal volume. And this is a dramatic change from treating all with this kind of large volume, and now nearly all or the majority being treated with small fields, which of course are also much better feasible and tolerable for the patients, causing less adverse events. As I said, another issue, of course, is, do we have tools to improve let's say, reduce the burden of treatment? And that is, of course, to deliver highly conformal therapies. This is just one example from the paper. This is dorso-ventral contralateral fields here for this mediastinal volume, and here it's a highly conformal treatment where you can avoid, for example, parts of the heart. So the societies are encouraging to use newer, highly conformal techniques if it's available. I want to point out that I know that it's not available in all the places you are. However, if you have it, I think a child would be a good target for such a machine if it's available. In the more privileged situation like I am in, we can even offer proton therapy It is in Europe and also in North America, but also in India or China. I think people try to offer it to children if it's available more and more, because it has a very advantageous dose distribution when compared to photons, who have the peak below the surface and travel through the whole body. The protons you can direct to the tumor target, and you have no exit dose because it is stopping in the tissue and will not travel through the body behind your target volume. And this is, of course, advantageous if you compare here two fields. One is traveling through the head and one is stopping in the target, and that's the proton plant. So that's why, if it's available, people use it. And this is also why we treat a lot of children, because we have such a machine. And we started with this in 2013 and have treated now more than 2,300 children. And lots of them are really very young. As you see here, median age of our patients was 6.5 years. And we have even children with age of half a year. Lots of them needing sedation for therapy, and treating them in all different sites, even if cranial and neck sites are most common in our place. The majority suffer from CNS tumors and sarcomas. We give conventional fractionation, typically with 1.8 grade perfection. This is just to say why I am also so much interested in pediatric radiotherapy. Even before I had access to protons, I started in Tübingen in 1995 to be specialized on pediatrics, and we had a LINAC at that time, and or two LINACs, and we did simulation with X-rays. So I also used, of course, other modalities to treat children, but I always dreamed of having a good tool to treat them, and that's why I'm in this field since more than 30 years now. So I said in the beginning that there are lots of situations when we cannot avoid to give radiotherapy. And I think, so when I try to kind of list what is the typical situation where we would offer radiotherapy, I think it's sarcomas, it is CNS tumors, also depending on risk factors, neuroblastomas, nephroblastomas, lymphoblastomas, even if here we treat less and less. And we also have retinoblastomas, but also here in Europe, where we typically see early stages, we don't use radiotherapy often anymore. And also in leukemia, we do not use radiotherapy anymore a lot. And also in hepatoblastomas, we don't use radiotherapy. But I think this depends very much on what your situation is. I guess you all know that we have typically lots of steps within the course of radiotherapy planning and administration. And I just want to briefly go through these steps, because I think it's really important also to, let's say, to acknowledge that every step is important to have a good treatment at the end. So as I said, we need to discuss the justification or the indication for radiotherapy. Why do we need radiotherapy in this case? I think this is a very important question to ask for every patient. When we feel we need radiotherapy, we need to discuss or consider carefully what is the strategy we want to use, what is the volume we use, what is the dose, total dose, and also single dose we want to use for the patient. So this is a very important step to take before we do any radiotherapy. And then I think we also know that the informed consent talk is really important. So we have to explain to the families what we have in mind. We have to talk about risks, but also of chances. And this will be a very important step also to ensure that the compliance of the patient and the family will be good. I think the better the family is informed, typically the better they will follow your suggestions. So this is also very important. Also, of course, from a legal point of view, where this is an issue, but also I think for the best compliance or cooperation of the patient. Then, of course, we have the step of planning. So how do we ensure immobilization of the patient? And then in this position, we also want to do the planning CT. And of course, we have nowadays image-guided radiotherapy, also meaning that we want to have optimal use of diagnostic imaging for treatment planning. So we may be able to register CTs or MRIs or even PET CTs of the course of therapy with our planning CT to register also the tumor volumes and come up with the target volumes from all information. So we try to typically get the imaging from diagnosis, from before or after surgery, and of course from the time of radiotherapy, and try to register it to our planning CT. Then we do the dose planning, and this should be a good plan which is discussed with physics. What is your expectation? What are the goals of the planning? So this is a very important step to come up with an optimal plan. And this includes also quality assurance, which typically is can be done in several ways. The planner do QA maybe by a peer review process, but also with doctors you can do a peer review process that you have done your contouring, you have done a planning, and then you present to another senior to discuss if what you did is reasonable. If you can explain it and he says, yes, it seems to be okay, then it's kind of reassuring for you. And then you have your first radiotherapy session, where typically also a lot of QA is ongoing to see that what you planned is applicable to the patient. And then you have your daily RT sessions, maybe also with QA, like X-rays, verifying the positioning, etc. But also verifying that the patient is tolerating your treatment. Bi-weekly consultations, checking how is the clinical course, is the patient well doing? Maybe you need a blood count to see if there's any hematologic toxicity or so, and maybe you have to take some measures, or patient has pain. So this is also important to be able to successfully complete the course of treatment. And then at the end, you have your final, or we have the final talk to also discuss how should treatment continue, or how should follow-up care continue. Is there a specific need maybe to take into account for the time after radiotherapy? And then, of course, we also discuss where is follow-up done, and we maybe also be involved in follow-up. In an ideal world, we would be involved. I already said informed consent talk is very important, and sometimes we do even several talks with the patients, because they have always questions. They always think and start to be afraid or whatever. So this is very important, but it can really help for the compliance. It can help to get through the course of therapy. So here it's taken very seriously to have a good information of the families. With immobilization, of course, in children, it is has some higher degree of complexity, because you always have to see what the patient would tolerate, ideally without sedation, but in some cases you may need sedation because the child is too young, or child cannot tolerate immobilization aids like masks, or to be alone in the treatment room. So therefore you have to here adapt, of course, to what is feasible, and you may even need anesthesia if the child is not able to consciously cooperate. We do a lot of contouring here, but this is of course partially also for scientific purposes. However, I think you need to at least take into account the organs at risk, which need to be considered for planning. So if we need to avoid an organ, we need to contour at least those organs. I guess many of you will not be able to spend hours on contouring, but you should consider what is worth to be delineated because you want to spare it, you want to give it a dose constraint, and therefore you need a contour in your planning system. Of course, also, I'm not sure who can use this from you, but however, there are, of course, some modern auto-segmentation tools, which are more difficult to apply in pediatric oncology because typically those, the data, those systems were coming from adult world. However, we typically try to do auto-segmentation and then check the contours and correct it, which is still faster as compared to delineating all organs on our own. But I guess this will not be available in many places. I think I want to highlight again that we all know that to treat children in radiotherapy is particularly challenging. If the child needs sedation, you need a set of anesthesia people to help you with that. You need them already for planning and then for daily care. This is complex. You may have also an issue with compliance of the family or of the child. It can be difficult. Also, parents can be very complicated and demanding, let's say, because they are full of fear, and this they try to satisfy by asking a lot of questions. And sometimes it's really difficult, but I think we need the full compliance of the full family in order to have a successful treatment. This may be very much time demanding. So how much time can we afford here for the patient? This is an issue, I think, with lots of pediatric treatments, that you feel that it's taking a lot of time, and still I feel it's worth it. And they can be extremely ambitious, also the parents, to help because they want the best for the child. So maybe we can use the eagerness of the parents to have a good cause finally. We also have efforts maybe applying to protocols. We need to read study protocols. They often give the gold standard in the protocol. So we want to read the protocols, but still we read that we have some timing issues to be considered. We may find parallel chemotherapy. This is really an effort. So you need the colleagues to discuss it. You go through tumor boards. We always feel that to treat children needs more time in lots of ways. And I know that this is a challenge. At the end, I come back with some idea, let's say, maybe how to help this at least a little bit. So as I say, we have the protocols which are complex, which mean that you have to consider timing of radiotherapy. You may have to decide what kind of dose you give, what is the response. You need to have a lot of information to understand where in such a protocol you find the radiotherapy for your particular patients. However, I feel that typically treatment protocols give a lot of guidance when you feel insecure what you should do. So maybe a good thing is to have a set of protocols, maybe not the newest ones, but maybe the last ones, because the newest ones is a scientific question, but the last one is maybe giving a kind of standard treatment, which is already understood to be feasible and successful, hopefully. Then, so if you can get hold of a protocol which was successfully running and feasible, then this may be a good hint for your own practice. So we, in our place, because we treat a lot of children, we have child life specialists helping the families during the course of treatment. For me, it's very clear that not all of you would have such a position in your department. However, maybe you have an experienced nurse who could help you to deal with the patients. I think it's really difficult if the doctor has to do all the talks and all the things, because the doctors are busy with the planning, with the managing of complications, etc. So, but a good nurse can be of tremendous help also to reduce the workload for doctors, and may be able to spend the time the patient is deserving, but you cannot maybe dedicate it to the patient. So I feel not always where I worked, we had child life specialists, but we typically had either an RTT or a nurse who kind of was really devoted to make life for children better. And this could be a position which is really of help in any situation to release your burden. We also have the opportunities to make some events, maybe. We even have some, let's say, private initiatives who come to play with children or to invite them to do sports, or where we are kind of also released, and the children and family are really enjoying it. And this can be a private initiative from someone who says, okay, I have 1 hour per week to do something with the children in your department. So maybe there's something you could imagine which would be doable in your place. I felt very interesting that there is increasing number of initiatives looking into how can I offer a good pediatric radiotherapy. So this is one example. I put here the web link of the 2nd edition of it, good practice guide. And I think what is really important is that also what is important to understand that it has several levels to offer good radiotherapy. It's not only to have a good machine or so. It's also good machine. It's also, of course, do you have the team? Is your team educated and trained? Are they aware of the research or maybe even involved? How are child and family doing in your environment? Can you offer that they feel okay in the environment they are in your department? How do you communicate with your colleagues? How do you communicate with the families? What about safety? Does the patient have a good experience in your department? And finally, of course, this all adds up to a top quality with regard to clinical outcomes. So you need a lot of different things to have optimal therapy and to have optimal treatment results. And I think it's, for me, I felt it was interesting to read this because there are, even if we may not be able to offer it all, I guess we may find some things which we can maybe improve, or where we find people who can work on that. This is another paper also on quality of radiotherapy, like how should we organize pediatric care. So I think this is of importance to understand what is kind of required to offer good radiotherapy. So if you have interest, you may want to read it. I said I would come back to the question of QA. So how do we do quality assurance? We have since about 10 years, I would say, or even, no, it's even 20. We have understood that it's not always easy to do radiotherapy in the best manner. And even today, in our courses that, sorry, can you mute? So we can also see within our courses that this is not for ELMIC, it's for HIC, it's for everyone. We can see that it's not always clear what we should contour. So this, for example, was supposed to be a brain volume from craniospinal radiotherapy, and you see how different the volumes are. So obviously it's not always so easy to do it all in the same and in the best way. So we try to understand what can we do to ensure that every child is receiving the correct treatment, and that's not easy. So in Europe, we have some even platforms nowadays where a review can be offered from external reviewers. So you can submit your plan, at least for special entities and within special protocols, and other people would check what you have done. And they may see mistakes like here, where a part of the volume was not receiving enough dose here in a brain tumor of the posterior fossa. So I think this is not always doable, and not everyone has access to such a platform. But what you should really look at is, do you have a peer in your department or outside of your department who could review a very challenging case, or in principle, every case? So in Europe, it's a prerequisite that every plan delivered was seen by a peer, by a senior peer. And I think this is something where you can maybe have a look what is available in your situation, or do you have a colleague in your department or elsewhere where you can have an agreement to look at the plans or the contours for a child, maybe when you treat some, and or at least some probes. I don't know what is kind of feasible for you, but I think it's very important to appreciate that we all make mistakes and that we need to find ways to prevent the children from having mistreatment. I think the professional societies try also to tackle this, to help with that by producing more and more guidelines and positioning papers, and giving recommendation how to deal with specific situations in radiotherapy. And you may know the papers. If you have time and access, you may want to look at it, because it really can help to deal with, for example, there is a guideline on craniospinal target volume done by the SIOP-E, or about bone growth for vertebral bodies. There is a paper. So there are some ideas, also some strategies how to treat metastasis. Here they have a kind of proposal also to offer hyperfractionated alternating radiotherapy if you have several metastases. So I think people really try also to share ideas and share discussions which are ongoing, and this may be of help. And of course, I hope that it's also of help that many people, and this is just examples from our department, that we try to use or to make use of the experience we are having treating children, and also of the resources we are having to also do research, investigating what we have done, investigating about side effects or investigating about local control, that we try to share as much as possible those experiences with all of you, because we know that you are not all able maybe to do this kind of research, but we need to share experiences in order to move forward. And I hope that all the research will help us all in the world to improve treatment over time. One example, I think what is also very helpful is the work of the PENTEC group working on normal tissue effects in pediatrics. So of course, we all want to understand the thresholds, those thresholds for particular issues and adverse events. And so they come up really with papers discussing those thresholds and those volume relationships for pulmonary toxicity, for example, or cardiac, etc. So I think this is also extremely helpful to understand what, as a radiation oncologist, you should take into account for optimal treatment planning in order to avoid a significant morbidity. There are also other research projects looking into side effects. This is really here a very hot topic. So, for example, this European project on health effects of fluoroscopy and radiotherapy in pediatrics, trying to understand better neurovascular effects, endocrinopathy, secondary primary cancer, quality of light, and cardiotoxicity. And so this is ongoing, and this work will be finished at the end of the year. And I think it's really important that we continue to work on improving radiotherapy care in children. So I would like to conclude and finish. We still today, even when having a lot of fancy chemotherapy and immunotherapy and whatever drugs, still radiotherapy is often indispensable for children with cancer, and the children may even be very young. We try to offer modern, image-guided, highly conformal radiation therapy in an individualized and risk-adapted manner in order to, on the one hand, achieve optimal cure rates, but on the other hand, try to best spare normal tissue. And I feel that radiotherapy, particularly in pediatrics, is really challenging due to not only technical evolution, but also to the evolution of the understanding of the risk factors and of the high complexity nowadays to understand what risk is associated for each patient. We need, in a way, a holistic approach of taking into account a lot of factors. I think it's of particular importance that we consider the needs of the children and the family, and it takes time. Protocols, guidelines, and studies are available and can be, I think, really helpful when radiotherapy is considered. I hope that the research and science, which is ongoing, that this will help to increase our knowledge on radiotherapy. And I think it is really important that we look with regard to radiotherapy into the multidisciplinary framework. We are typically not alone. We need the colleagues. Hopefully you have the structures in place to be able to look at it with a perspective, not only from you, but also from your colleagues from oncology or radiology or pathology, in order to have a full understanding of the case. And with this, I would like to finish, and I'm really thrilled to see that we are more than 150 people. Thank you so much. I'm really happy that we are here today, and I hope that this will be only the start for this series of lectures. Thank you.
Thank you, Dr. Timmermann. This has been great, very fruitful and elaborative on the basics of pediatric radiation therapy. We have a couple of questions in the QA as well as the chat box. So one of them is regarding the ideal age to treat a child with radiation.
Sorry, I didn't understand you.
There's a question by one of the participants, and the question is, what is the ideal age to treat a child with radiation?
Sorry, what is the
age, the perfect age?
Now I even hear you worse than before. Sorry. Maybe I have to make my, no, I cannot.
Can you hear me now?
Yeah, this is better. This is much better.
Yeah.
Yeah.
So the question is, what is the ideal age to treat a child with radiation?
Oh, that is a, I don't know. I don't think there is an ideal age. So we used to say, let's say, the minimal age is 3 or 4, but unfortunately, we have learned that this is not true anymore. We even treat children as young as 1 year of age. So ideal, let's say, in a way, is of course having a child which is already fully grown. So I guess after 14, 15, 16, it's much easier as compared to the very young. But there is no ideal age. I think the problem is also you don't know even if there is any, let's say, cut off where it's easy. There is no cut off where it's easy. We have even understood that this adolescents and young adults age group is really difficult. And there are some late effects, for example, infertility, where girls are even more vulnerable when after puberty as compared to before. So therefore, you cannot give, unfortunately, one age. The older, the better, I would still say in general.
So there's another question regarding the integral dose associated with IMRT and 3D conformal radiation therapy. And it asks that what does the issue of integral dose arise when IMRT VMAT is used instead of 3D conformal, and how do you address that?
Yeah, so of course, I personally have an easy answer because I address it by giving proton therapy. So proton therapy is not having this dose bars issue as we see it in IMRT or VMAT. However, I think there is no general answer. So what many people are do is that they plan, for example, 2 plans, one with 3D conformal and one with IMRT and VMAT. And depending on the, let's say, advantage you would have from the IMRT plan, you would decide if you accept the dose bath or not. We do not have the data to understand how big the clinical relevance of this dose bath is. So I think that most of the people have moved to VMAT and IMRT, even if there is the dose bath, because you have a lot of advantages to spare particular organs. So if IMRT would help you to preserve function of kidney, for example, you may do it even if you have a dose bath. If you're not going to achieve anything, maybe in an extremity tumor or so, then you may do the 3D conformal treatment plan. But I don't think there is a general answer. I think you have to decide it case to case. But IMRT and VMAT may give you a significant advantage over the 3D conformal plan, and then you should go for it.
Okay. So can we take some more questions, Beate?
Yes.
Yeah. So how is pediatric radiotherapy different from adult radiotherapy? I think you touched upon that, but if you want to describe again.
Yeah, I think the difference is, from my point of view, that you have a higher risk for late effects and also other late effects maybe you are concerned of as compared to an adult. Then you have more, from my point of view, logistical issues, like maybe you need sedation. Typically, they have more chemotherapy as compared to adults. I think this is also may come with lots of problems. And what I think is also in terms of the guiding the patient is that you have the full family to guide. You don't have, we typically say, is not the child only your patient, also the family is your patient. So you have to include all the family into your strategy and into your conversations. And that's also a higher level of complexity. And what is also different, I think that the survival rates are in general better, which is very motivating. So we have typically very high tumor control rates in those children.
Okay. So there is a disease-specific question here, Beate, regarding Wilms. Is palliative radiation to chest with 12 gray in 1.5 gray justified in a 4-year-old patient with Wilms who has failed twice with systemic chemotherapy?
So what was the dose? 1.5 gray perfection and total dose?
Yeah, 12 gray.
And this was, the patient was previously treated?
Yeah, twice with chemotherapy. It doesn't say the radiation dose.
I think those situations is difficult to give a standard anyway. I think you can try. There are also low doses can be effective in Wilms tumors, and I think the previous dose burden has to guide you. You may not be able to offer all what you know. I think here you can adapt a little bit individually.
So one of the participants has a question that they have a high number of referrals for pediatric population for palliative radiation therapy, like superior vena cava syndrome. So what should be the palliative radiation therapy dose, and are there clinical guidelines available for palliative radiotherapy in children?
Yeah, palliative radiotherapy is really a very difficult issue. I think it is hard to give you, I think, a general dose strategy, if that is what you would like. There's one paper, unfortunately, I don't remember the first author. I know that Karin Dickmann was also involved. There is one paper having, let's say, summarized the strategies which are used among, I think it was among Europe. And that was that is kind of interesting because it kind of summarized the options you are having. I think it's also giving the entities where it was used. So for example, 5 times 4 gray, 10 times 3 gray, 1 times 8 gray. So there are several options. And I think those options need to be adapted to the feasibility in terms of logistics, in terms of expected lifetime, in terms of course, the site where it is. So you may be braver to treat something at an extremity as compared to something in the brain or wherever, depending also on pre-treatment. But I think I would advise to look in such a paper. You know, I don't think I can manage to. Maybe Bilal, I can look for the paper and you could distribute it to the group. I don't know if that is possible. I can check for the paper. So that, because I think I'm using this sometimes myself. I look into the different options and decide what kind of option could be an option for my patients, because we have so few data on, so no standards on palliative care, that I think it's still good to be able to refer to experiences which were made elsewhere. So Bilal, I don't know if that's possible that I search for that paper afterwards.
Yeah, maybe we can put it on the
I could,
PSYOP and the PROS.
yeah, you know, I could also search for it now, but then it will be difficult for me to answer your questions when I'm still searching.
So if it is from 2021, pediatric bladder cancer written by Derek Sang, I'm just able to post the link.
No, maybe, but this is maybe, no, I don't think this is it. But I put something in the chat. This is not the correct one, but it's also good. Sorry. Can I write in the chat?
Yeah, you can.
Yeah. Did you receive it, or is it too long maybe? I don't know. I think it's too long. It's not accepting my, I don't know why. No, I cannot send it. I don't know why.
I have sent one from Derek Sang from pediatric bladder cancer in 2021. Maybe you can check that.
There is one from pediatric bladder cancer 2017, which is also nice. I don't know why I can't. This is from Rao. And once was here's another one. No, I think this is the same. So I can offer to search for it and send it to you after. I'm not sure why I cannot send it. This is really a shame.
No, that's okay. There are so many more questions. I don't know how far do you want to go with that. Okay, we got this one from 2017, the chat box.
Yeah, I'm happy we still have, let's say, 10 minutes or so. Okay. I have a meeting at 5 and I have to walk half an hour to the meeting. So you can still ask some questions. I think it's, I'm so happy that you have interest, and it's fine for me.
Oh, that's been wonderful. So the next question is regarding the follow-up strategies and assessment of radiation side effects, considering these children may not express symptoms or complication in the same way as the adults do.
The last thing I didn't understand. So follow-up strategy.
Yeah, follow-up strategy for the side effects, as children are not able to express the side effects or problems as the adult patients express their problem.
Yeah, that's true. Of course, I'm not, let's say, a specialist on it, but you know, some of the issues you may see in the diagnostic imaging, some of the issues you may see in the blood counts, and some of the issues may be reported by the parents, because typically the parents are very sensible to any change in behavior of the children. So it's true that you will not maybe hear from very young children, but once they're older, they're also addressing what they have, and some you may simply see also from outside. In a way, as long as you don't see it and the parents don't see it, typically it may not be already that, let's say, bad. However, of course, we typically do, as I say, also follow up by diagnostic imaging and by taking blood. And therefore, you have options, or you may need use an ultrasound, for example, to look into the child. And there may be options, or an X-ray. So depending on the problem you are expecting, you have to, of course, think of how could you detect it, even without the children telling you. And family, you have to investigate also the child, you have to ask the family, and you can decide on some diagnostic interventions. And of course, it would be good if you have a picture of what you expect. So when you treat a region, you typically have a kind of list of what could happen. And then you could think of what is the investigation to offer or to do in order to find it. But of course, there are also lots of people saying you should not overdo, because this is a tremendous effort, not only for you and for your resources, but also, of course, for the family, who are always afraid that something could happen. And sometimes you see findings you don't want to see, or you don't know what to do with it. So it needs to be a balance, but have a clear picture of what you expect, and then try to find a way to see it or to understand it if it has happened to the child.
So is it better to defer radiation therapy of brain beyond 3 years in medulloblastoma children and use chemotherapy for children who are younger than 3 years?
You are now again not very loud anymore, Bilal. Sorry, but then I have difficulties to understand you.
So about medulloblastoma radiation therapy, is it better to delay radiation therapy beyond 3 years and use chemotherapy for children younger than 3 years?
We used to do that. I think if I say it right, let's say there are some, the problem is with medulloblastomas that we now have several groups of molecular findings, and it's not only one group of medulloblastoma anymore, it's several. But for the young ones, where we try to defer radiotherapy or to avoid radiotherapy by giving chemotherapy, we now have a group of patients where we see a lot of recurrences. So from my understanding, it is now under review for what part of the cohort we can defer radiotherapy and where we may need to offer early radiotherapy. So I don't think we have a clear view at the moment on it. I think you really need the pediatric oncologist to understand the risk profile of the patient, maybe with some molecular findings, if that's available at your place, and discuss individually with your group. So we try currently to defer radiotherapy, but we feel that it is a risk for many of the medulloblastoma patients. But I don't have the answer for you, and particularly not without looking into the molecular subgroups.
So there's one question, Beate, about dose compensation when there are treatment gaps. So in adults, there's a strategy to compensate for the treatment gap. Sometimes you give twice daily fraction like PID after 6 to 8 hours on a single day. So do you know if there is a way to compensate the gaps in pediatric patients?
I wouldn't say there is any standard. In some protocols, you may find a note how a fraction you missed should be compensated, but I'm not sure I can refer to a protocol. So what we have, let's say, a kind of standard in our house saying that we do not allow a prolongation of the planned course over 2 days. So we accept 2 days of prolongation, for example, by having missed 2 fractions in the full course, either by patient was not well or there was a holiday beside the 2 weekend days, as in addition to the 2 weekend days, holiday or your facility was down or whatever. So 2 days. If it's over more than 2 days of delay of the planned schedule, then we start to discuss compensation, either by adding 1 or 2 fractions or by having, as you say, one bi-daily fraction on 1 day, for example, or by increasing the dose per fraction. This we also do sometimes. However, it depends very much on the case and on the organs at risk. When you have already reached a dose constraint for chiasm or for brainstem or for a really important organ, then you may feel that it's not feasible to add more fractions. So you have to balance, from my point of view, you have to balance individually. But we typically start to discuss dose compensation after prolongation of more than 2 days. And then we try to find what is feasible also for the family. Maybe they have booked flight back, etc. And then we give twice daily at the end, or maybe we give a fraction on a Saturday where we didn't plan to give a fraction. So there are different ways to do it. But there are some, so typically unfortunately, most of the pediatric cancers are fast growing tumors where we feel we should react to a treatment interruption. So, and as I say, take the 2 days as a rule of thumb and then try to see what you feel you can offer. I think we need to discuss dose compensation if we have a longer break.
Thank you. So Pentec is relatively new, Beate. Pentec for dose constraints. What were you used to do before we know we had Pentec?
Yeah, so I think still that we look still in EMAMI lists. So, and I have to say that this is still true, or we believe it's true for many organs at risk. And then, of course, we have lots of protocols. We have some dose constraints given. And I think that we look still today a lot in the protocols in order to have our dose constraints. So even if I looked into the Pentec data, I think in our planning systems, etc., we still have kind of old-fashioned dose constraints from EMAMI and from the treatment protocols, where also the dose constraints are not very innovative. I would suggest to look into the protocols. With that, you cannot really mistake a lot from my point of view.
So I think this is the last one. So how about using the FFF? I think this is the flattening filter free energy beam for reducing the risk of second malignancy.
This was again difficult for me to understand and to maybe both from. Is it written here somewhere? Maybe I find.
Yeah, it is in the Q&A. Is the idea of using FFF, flattening filter free energy, for reducing the risk of second malignancy. Is it relevant?
I'm not sure I know anything about it. FFF.
Yeah, I think it is for removing the flattening filter.
I don't know. I don't think I know about it. Is it, maybe it's not on protons. Maybe it's something I don't know because it's from photons.
Yeah, it's a photon thing for SBRT or radiosurgery. It's like, so the last one is about SBRT in pediatrics, or stereotactic body radiation therapy.
Yeah, we have not a lot of data, but of course it just means that you have a higher precision. So I think if you have a tumor where your SBRT can give you high precision, then it may be of help. Of course, it may not mean that it is hypofractionated. So you can use stereotactic body immobilization techniques also when you give fractionated radiotherapy. And typically at least for curative diseases, we use not a lot of hypofractionation. We use typically conventional fractionation in children because we want to avoid a higher risk for late effects. So I think depending on the case, you may use stereotactic body immobilization techniques, but still give fractionated treatments as the standards typically say. However, of course, you also have situations where you treat metastases, maybe with few fractions or even single fraction, or liver metastasis, or these kind of things. You may even go for hypofractionation or single fraction. But I would say the typical dose concept is conventionally fractionated, and then you can only use, or then you can still have the help, let's say, of the stereotactical body immobilization techniques, because we have, of course, to treat, for example, upper abdomen, or maybe even thorax, where this may be of help. And so therefore, yeah, if you don't use it for single fraction treatments, then I think it can be of help. Or you do it only for metastases.
Yeah, I think that's all. I hope I've covered all the questions. So that's pretty much it. So shall we conclude? Yeah.
Janet had this
Yeah.
question of FF beams. I see it now. Okay. Yeah, sorry, Janet. I'm not competent in this field. Okay, Bilal, you want to close the session?
Yeah, I can. I just thought if Janet wanted to say anything at closing. Not sure she can unmute or say anything, but I think we can. No, we have had a great session. Thank you, Beate. Wonderful attendance. I think the maximum participants touched up to 175. Mostly it was 150. So thank you, everyone, and thank you, Beate.
Yeah, thank you. I'm very happy. And Bilal, we will announce the next date as soon as it is clear. We are now making the next appointments, and we hope to be able to let you know soon.
Sure. Thank you, everyone, and thank you for the wonderful participation.
Bye.